Well, good afternoon, everybody, and welcome to SADS Facebook Live, or good evening or good morning, depending on where you are across the globe. So I'm Mike Ackerman, and it's great to join you for episode number 14 since the COVID-19 pandemic, where we have joined you on most Fridays to try to take your questions and see how you're doing and give you the reassurance that you deserve that we will live and thrive together despite this pandemic. So I'm a genetic cardiologist, as you know, at Mayo Clinic and serve as president of the board of the SADS Foundation. So along with Alice Laura, the CEO of the SADS Foundation, thanks for joining us. And it's a real pleasure to have Dr. Susan Etheridge back with us. This is her second time returning of these 14 episodes. Susan, welcome.
Thank you. Great to be here.
If those of you don't know, Susan is the vice president of the SADS Foundation, and we have been partners in crime now for many years, Susan.
20?
I think it's been 20. So for those who are starting to join us, thanks for joining us today. And want to give a special shout out to several philanthropists and benefactors, supporters of the SADS Foundation. Thanks for joining us today. We could not do this without you. As you know, the Sudden Arrhythmia Death Syndrome Foundation is arguably the largest nonprofit advocacy organization devoted to families like yours and those of you who support it with these sudden cardiac arrest and tragically sudden cardiac death predisposing genetic heart rhythm conditions. But the good news over Susan and my 20 years together is that we have moved the goalposts. We don't expect sudden death to occur in our patients and families. We expect instead our patients and families to live and thrive. And Susan, maybe comment a little bit about, since it has been kind of 20 years together, what's been some of the dramatic things that you see with our families now when we diagnose them with long QT or CPVT or Brugada compared to when we first joined the SADS board 2 decades ago?
I think there are several important. I think one of the really important is that we are now diagnosing people in the pre-symptomatic phases of the diseases. So we are avoiding syncopal events, avoiding sudden death. It's easier to diagnose them. I think we have a toolkit that involves different clinical testing and genetic testing that really lets us get to the answer quickly. And I think one of the most important things, and the things that I bring up with my families are, once you have these diagnoses, if you play by the rules that we set out for you in clinic, it's very unlikely that you'll experience even a syncopal episode, much less a sudden death episode. So I think that the greatest strides I've seen is in our therapy, and it's been a really fun bench to bedside. That's what we talk about in medicine, where we talk about the bench being where the basic scientists like Michael help us understand the disease and then bring therapies and diagnostic tools to the clinical arena and then use those data to come back to the bench to explore the disease further. And I think long QT syndrome and CPVT are two excellent examples of real bench to bedside successes.
Yeah, it's an exciting time, isn't it? And a shout out along therapies like Susan mentioned. I know Long QT Therapeutics is a new company that I know they've come online and joined us for the SADS Facebook Live in the weeks past. And just to let the families out there are companies like Long QT Therapeutics and others that have said, we're not pleased with the status quo. Let's try to come up with even better therapies for long QT syndrome and other genetic heart rhythm conditions. So thanks to our pharma partners and those who are trying to make advances so that the therapies of tomorrow someday won't be beta blockers, that eventually will even take another step and come up with something fundamentally different. So we thank them, and those are joining us. We give a greeting to those from Berlin who've come on.
South Africa?
Yeah, what time is it there, Chantel? My goodness. Past my bedtime, I think. and we're starting to have some questions. So we're going to pop back and forth, Susan, with questions and some of our things that you and I were thinking about before we came on. But let's start with Deanna, and she's from Palo Alto, California. And Deanna, I love California, but I have to tell you, I love that my son, his wife, and my almost 4-month-old granddaughter has left California. They're closer to home. So I'm happy about that. But Deanna, you're a marathon runner, and she's wondering, Susan, whether she can still go running. And I think this is a great link to what you and I were just talking about, is how much things are different now than 20 years ago. What would you say about her running and kids dreaming big, even though they might have long QT syndrome?
So I have had a total paradigm shift in how I care for people with long QT syndrome. A lot due to the data that you've put out and others have put out about this, the ability to safely participate in sports. And it's always a balance. You have to balance safety versus risk, but there's risk to just sitting on the sofa too. So I have encouraged my patients, I'm a pediatric cardiologist, to be involved in sports, even competitive athletics. And again, as long as they are compliant with our recommendations, yes. And I would probably let you run a marathon if I were your doctor. I'm not, I don't know anything about you, but I would really lean in the direction of continuing your life as it was before you were given this diagnosis.
Yeah, we certainly do everything we can to make that a reality. And like Dr. Etheridge pointed out, it depends on a lot of factors as to whether we would implement any precautionary measures. But it's a different day. And I think, Susan, I just saw a patient earlier this week live, across from each other, not by video consult, with masks on. And you could see behind his mask a huge smile when he learned that he could actually do sports, because he's been shackled for the last 6 years under the old thinking of, if you get diagnosed with long QT, you can't do anything. Don't get up off the couch too fast, because your heart rate might be going too fast. And for all of the families out there, it really is a new day. For those who are long QT specialists, like Dr. Etheridge and myself, where we try to let you live large and really large. So I think that's encouraging. Naomi, hello from the United Kingdom, and let's come back to, we are in the COVID-19 pandemic. Some of us have tried to start to forget about that, and maybe that's a good sign. But Claudia is from Austria, and I wish I could be there. We missed going there when we were grounded from travel, and I was going to be in Vienna with Dr. Etheridge, but she's wondering whether COVID-19 has any effect on patients with CPVT. She's read some articles, but she's wondering, is she at higher risk for serious COVID-19 because she has CPVT? Susan, what do you say?
It certainly doesn't in any way affect your have an increased risk of you contracting the disease. I think that no. As far as CPVT and COVID, as long as you are not one of those incredibly ill patients who is in shock in the ICU requiring adrenaline, then I wouldn't think that your disease would make a great deal of difference. I don't think that the traditional therapies that people are using for the COVID-19 have any real impact on your CPVT, with
Yeah,
the
and
exception of resuscitating drugs.
right. And Susan and I and the SADS Foundation, of course, we want all of you to stay corona free for as long as you can. And not because we're worried that the coronavirus will make your long QT worse, or that your long QT or CPVT will make your COVID-19 worse. It's just good for us to stay coronavirus free for as long as possible, because we're learning so much. But while we think that's true, Susan, are there any diseases of which we take care of where you and I want them to stay corona free even longer, because we are a little bit worried about it interfering with their heart, or making their disease worse? Or
What do you think about arrhythmogenic RV cardiomyopathy? That would be the one that there might be a signal there. I don't think that there aren't enough patients yet for us to understand it fully, but
right?
that would be the population I would most worry about.
Yeah, and I agree. I think that's where, I mean, the good news is we have no data. And
No,
the reason we have no data is because
no
we're not
cases.
aware of any of our SADS Foundation families having significant disease, which is great. And so we don't have a signal. And that reminds us to remind you about the SADS survey. There's a survey for you to share with us. Have you gotten infected with SARS-CoV-2? What's been your experience? What have been your symptoms? And so that we can see whether there's a signal. But we haven't seen a signal of any of our SADS families in North America. We've talked in Europe, and we had not seen a signal as of a couple weeks ago in Italy, Amsterdam, Australia, for when we had Chris Samsarian on. But Dr. Etheridge pointed out ARVC, which I think when we had Dr. Hugh Calkins on and their genetic counselor at Johns Hopkins, that is a disease that they would like their patients to stay corona free for as long as possible, because they think that there is a setup where the virus infection, if it infected the heart muscle, could make the ARVC disease progress. Or at least that's the concern. But again, Susan, I think you're right. We have no signal yet, which I
No,
guess is
no.
great. So let's go way to Chantel. I think, Susan, you and I were in Cape Town together.
Mm-hmm.
I love that country. And her son is on beta blockers for long QT. And we might need some help there, because I don't even know that drug, Cilazaprine for CRMO.
I'll look it up.
And is wondering about the possibility of weaning off the beta blockers, being worried about kidney damage. Chantel, we're going to park that one a little bit. Maybe Alice or Aaron in the background can tell us what that drug does, and even CRMO, because full confession, I'm not even sure what that acronym stands for right at the moment.
It's boy, all I found was sulfasalazine. Maybe she means sulfasalazine for Crohn's or ulcerative colitis. I don't know.
Okay,
Good question.
Chantel, that's a great question. We'll do some investigating and get back to you by the end of the show, or next Friday. Let's go to Frank. So Frank, appreciate the question, and he's asking about. I guess we could take it in general. What do we think of the current therapeutic landscape for COVID-19 in general? What are your colleagues telling you in the infectious disease world, Susan? And then specifically about losartan. So you can take it in any way, and I'll follow up with some comments on the current treatment landscape for COVID-19. But remember, out there, we're just cardiologists, Susan and I. So we are not infectious disease specialists, but we do read the literature very carefully. We have a pretty good pulse on what we think is looking positive, what we think is looking underwhelming, and we'll give you our 2 cents worth, and they're free. Those 2 cents are completely free. But Susan, what do you think about the treatment situation for COVID-19 right now in general?
I'm going to start with the losartan question. I think that there have been studies looking at being on a losartan or an ACE inhibitor like lisinopril. And I don't think the data are convincing that these medications make you better or worse. And most of the advice right now is that obviously you were started on this medicine for a reason, and continuing that medicine and the way it helps you is my advice and most cardiologists' advice. As far as other therapies, Mike, you'll be able to speak more about the quinolones. But remdesivir, I don't think there's any, the data are still out. I don't think we know. There have been some studies that suggest it attenuates the disease. It makes you have the disease less long, and maybe a signal that decreased mortality, but I don't know that those data are as clean as they should be. But no signal for harm with that antiviral medication and any of our patients that we deal with, any of our conditions that we deal with. So, and I'm going to turf it to you because I know you know a whole lot more about the hydroquinones.
Yeah, I think that's great news, though, isn't it? That if our infectious disease colleagues give us the green light to go with remdesivir because of efficacy, I think what you just said is we're not worried at all about the heart effect. So that's great. And then I think right now for the Corona cocktail of hydroxychloroquine and azithromycin, I think we can probably say with a decent amount of confidence that the efficacy signal, if you are sick with COVID-19, is a big thumbs down. And the cardiac risk, which we've been warning about for over 2 months, is real and measurable. So I don't see any upside. And for sure, a sick COVID-19 patient who happens to have long QT, who is one of our patients, will never get permission to be put on hydroxychloroquine based upon that current imbalance between efficacy and risk. Now, what we don't know is what about taking hydroxychloroquine in a anti-malaria way, like prophylaxis, so-called post-exposure prophylactic therapy? And the studies are out there. There's some very large NIH-funded trials and also a study funded by the Bill and Melanie Gates Foundation at UW Seattle, looking at that. And if there is efficacy signal in that context, that's going to be great news, because when you are well and you're taking these medicines are actually incredibly safe to the heart, and probably even safe if we had long QT syndrome. So we will be waiting and watching, like all of you, as to what is the verdict in the post-exposure, I'm not yet sick, but I just got exposed setting. So stay tuned on that one. But it would be great if it works in that setting, because the cardiac safety margin in that setting is going to be really, really good safety margin. And so I don't think we have to be worried. But I like, Frank, your question on losartan. I think be sure, if you are a cardiac patient and your doctor has put you on losartan, do not stop it. There's some data just kind of coming out that is encouraging.
Yeah.
That it actually might have a little bit, or potentially more than a little bit, of a benefit signal, which scientifically it makes great sense, because it's countering, the virus hijacks the ACE2 receptor and steals that receptor to gain entry into the various cells. And losartan could help counter that move a bit. And so I'm watching that study. I know it's headquartered out of University of Minnesota, which, just memory lane for some of you out there, Dr. Susan Etheridge went to University of Minnesota. So she's a former Golden Gopher.
I'm also, in all honesty, on losartan, and I have not stopped it.
Yeah, so don't stop. Well, that's great. Adrian, I want to give a shout. I did mention Long QT Therapeutics, and I'm glad that they've come into the world of trying to make a difference in Long QT. But Adrian has joined us from a profit advocacy organization, LifeSure. I love this company. I use it. I refer my patients to it. And this is an entity that helps Dr. Etheridge and I secure automatic external defibrillators for our families. And they do a tremendous job. So Adrian, thanks for, and on behalf of SADS Foundation, thank you for what LifeSure is doing for our SADS families. Now, the good news is, when we treat our families well, like Dr. Etheridge was talking about, the number of times we've had to use an AED to rescue our patients in the last 20 years in our program is 3. In other words,
2 for us.
2. So Susan, 1. So meaning
smaller patient population.
This is Boy Scout Be Prepared measure, but it's one where we will almost never need it, but it's a great piece of safety device to have in our homes. I have a fire extinguisher in my home and we've never used it, but I know where it is and I know how to use it. So thanks, Adrian and LifeSure.
And actually, a patient is on saying that LifeSure helped them get their AED. So thank you.
Yeah, that's great. Let's take Jesse's from Germany. I did one semester of German in college that was required for a chemistry major. And it's not very good. So I'll just say Danke. But her question, Susan, is she has CPVT, newly diagnosed. So she's only 3 months into this journey. And she's on propranolol and flecainide, low dose. She's very scared to do any exercise. What advice would you give her to sort of how she and her healthcare team will help her get back on the saddle? Maybe what do you do with your newly CPVT diagnosed patients to help them get going again, especially if their first event occurred during exercise?
Right. So how I treat these patients is I use Nadolol, but I think that has some limited availability in Europe. So propranolol would be a reasonable second choice. Push that to the limit that patients will tolerate. And I do use flecainide. I get patients started on their medications and then I put them on the treadmill and run them in the clinic. If they're too little to run or for some physiologic reason can't run, then I'll put a halter on them or some other form of monitoring, but preferably an exercise study, really to give me reassurance that the medicines are working, but also to reassure them that they're going to be safe, that their disease on these medications is going to be safe.
Yeah, I think getting you going, be patient with yourself. It takes time to get the courage up that life is different when your CPVT is well treated with the strategies that she talked about versus untreated when it reared its head in the first place. So you'll get there. Chantel has helped us out, Susan. So Chantel did some homework in South Africa for us, and what she's really getting at is she's worried about her son when he of getting a SARS-CoV-2 exposure when he's on two quote unquote heavy meds, the one for his long QT, the beta blocker, and then also for his CROM, which is or CRMO, which is chronic recurrent multifocal osteomyelitis,
Oh,
because it's an inflammatory condition. Um, do you want to do
I'll
that
take
one?
on the Nadolol. I
Yeah,
don't think that there's any risk of this disease with Nadolol, and your bigger risk is stopping the Nadolol. I don't know anything about the other drug. If it is an immune modifier or modulator, that might increase your risk, but it's also you're talking about a child, and the incidence of this bug getting our kids is quite low. It represents a tiny percent of most of the cases around the United States, around the UK. Typically less than 2% or 2% or less of the affected people are children. So I think you're probably in a pretty safe zone there.
yeah, I agree. I think it's great news that only 2%, if that,
If that.
affect children. But she's saying about being exposed, and I guess I would add to that, Chantel, that the things that we have all been doing, 6 feet apart, wearing a mask, these things actually work. So I want all of our patients and families to stay coronavirus free for as long as possible. So keep doing those. We've seen in our own community, I'd be curious what you've seen in Salt Lake City, Susan. My wife went to a grocery store in Wisconsin and she was the only person with a mask on, the only one. Whereas in Rochester, Minnesota, if we go into the grocery store, 90% had their masks on. And are you seeing people sort of swinging the other way and sort of saying, oh, forget this, we're just going back to normal as if this thing doesn't exist, which I think that's a little bit not a good idea.
I think that's very cavalier. No, I live in Utah. We're rule followers like you Minnesotans are too. And there's also people are actually commenting, not I like your dress, but I like your mask. And so people are wearing them. I don't, my husband does all the grocery shopping, thank you God, but everybody's wearing them at work, the only place I go to. And I even see people driving around alone in their
Yeah,
car wearing a mask.
that's a little on the funny
It's a
side.
little much, yes, but I still think I think it's good. I agree with Mike entirely. We are not in the place where we can take our masks off yet.
Yeah,
And
not yet. And there was a great study earlier this week that showed that masking, at least when you mask the hamsters, is an interesting design they did with the hamster cages, but masking works. It decreased the exposure risk by like 75%. So, I've told people that unless there's no COVID-19 in your community, put the mask on when you're in the public square for now, and just do it. Um, this is another. I'll give you. This is a fun one, Susan. I'm not on Facebook. Are you? Okay, so I don't really know. But for whatever reason, if my mother does a Facebook posting, it shows up in my email box. I don't know what button I need to turn off, but her Facebook posting on Monday said, I just heard a doctor say we don't need to wear our masks. I've been right all along. To which I posted my first Facebook response ever to my mother saying, Mom, you listened to the wrong doctor. So
exactly.
maybe listen to your son on that one.
And I think wearing a mask, you're actually protecting other people more than you're necessarily protecting yourself. And so I think it's the right socially correct thing to do.
Right. For now.
Yeah, for now.
And I can't wait until we can get rid of them, because I must say, and I've seen some of the families who've joined us online, who I've seen in clinics since we started, mask, I mask, you mask, we all mask together. I don't like it. I miss seeing your faces, your smiles. It's just not the same, but it's as good as it has to be right now.
I care for babies, and it's really hard to be in a room with like a 4-month-old, and you have a mask on because you can't get that great 4-month-old smiling interaction while you're wearing a mask. So it'll go away.
Yes. And this Beth, you're very welcome from Ohio, and I'm delighted. I think I know who takes care of you there, and I would agree. You are in great hands, so I'm glad things are going well for you. Um, let's see. And Trent already acknowledges the impact that LifeSure had to help them. So some immediate feedback there. And Janine, you can work with the SADS Foundation. We can help you get more information on how LifeSure can help you. I use them all the time um, and I must say, they must have the sweet sauce formula, because when we go through LifeSure, they almost always secure an AED for my families, regardless of the insurance landscape. So I got to say, I think their batting average in our program to getting that family their safety gear has to be at least 90%. Susan, have you had a chance to be utilizing that organization yet too?
Yes, and my nurse does a lot of the engaging with them, and we've been very, very pleased. That used to be one of the hardest parts of our job, and took a lot of time and a lot of letter writing. But I think it is getting better, and thanks to
Yeah.
organizations like LifeSure.
Here's a good question, Susan, from Mary. And again, today, these have been like the last 13 episodes. You guys out there in SADS Facebook Live territory, you ask great questions. So Mary's healthy with LQT2, who also, by the way, has arthritis. And if her arthritis specialist wanted her to be on Plaquenil, which is hydroxychloroquine, would we think that would be reasonable? She has a pacemaker and a defibrillator as part of her overall long QT treatment program. thoughts on that about treating all of our patients and things like that?
I think that's something, you'll have to obviously explore with your physician because they know more about what your resting QT interval is, et cetera. But there are safe ways to use the drugs on the don't use list. And it's really a risk benefit. If this drug and it works well for your arthritis and you try it and you feel better, then it is something that I think likely can be done safely. I think there would be other considerations like being sure not to mix it with other long QT2 blocking or AGERG blocking medications, to do ECGs in the baseline state and then after starting the medicine or with any medicine change to watch your serum potassium and make sure it stays on the high side of normal. But there are ways to make these drugs safe. It's just like everything we do in medicine. Every single person is a different patient, and we have to think about them like that.
Yeah. And I think, Mary, a sneak preview into what the future is going to look like. Dr. Etheridge mentioned getting an ECG before and after. We're not far away from having
Yeah.
a QT meter on your phone. And so Mayo Clinic, full disclosure, has partnered with AliveCore and their cardiomobile device over 3 years ago to come up with a QT solution. And actually, the COVID-19 pandemic has helped accelerate that interaction and that effort because the FDA granted emergency use approval for the cardiomobile device as a QTC monitor for COVID-19 therapy. Then very quickly, we will soon have an indication in the near future of a general approval of AliveCore as we are able to have it report out your QTC value. Now for our long QT patients who need to be on drugs that might have a QT signal, it's going to be so easy to do a spot check whenever we want, whenever you want, to see what your QT interval is doing and is it reacting to the medication or not. So I think we are on the verge of doing QTC monitoring uh, in a way that puts an end to the 100-plus-year-old Eindhoven 12-lead ECG in the office way. So it's I think 2020 is going to be a great year for bringing about a transformational new way of doing QT monitoring for all of our families. So, Mary, I think we'll have a way that you will be able to safely take it now and in the future. Let's see, do you see one? We have about 7 minutes. Chantel, you're doing a great job. Thanks for the follow-up.
There's Carrie who's asking about who has a child with inflammatory syndrome and worried about this multi-system inflammatory problem.
Take that, Susan. That's a great one from Carrie.
Yeah. One of the new things that we're starting to discover about this COVID infection is this late complication that is occurring in children. The disease resembles something we call Kawasaki disease, which is an inflammatory disease. And it is multi-system involvement. It does involve the heart, causes decreased function of the heart, causes coronary artery changes in the heart, and a lot of markers of inflammation go up. I wouldn't think that somebody who already had an autoimmune disease was at increased risk from this. I think that there is going to probably be a genetic signal as to who is at increased risk for this multi-system inflammatory syndrome of children, which is MISC, kind of an odd an acronym. But I don't know. Would you, Mike? I would think that the risk of contracting this would be genetically determined, but possibly not in any way overlapping with their present autoinflammatory syndrome.
I agree. We don't know, but I totally agree with you. I think you're exactly right. And I know this is on the news a lot right now, this syndrome or the multi-system inflammatory syndrome of children. But we have to keep in mind, like Susan said earlier, less than 1 out of every 50 COVID-19 patients is a child. And so far, none of our SADS families have called us to tell us that they even had COVID-19 in any substantial way. I still haven't, or at least if I had, I've been completely asymptomatic. I haven't even had the PCR or the serology yet. My college son did when we extracted him from college, and he was PCR negative. Um, Susan, I assume the same is true for you and your family. You're corona free still.
Corona free. I was tested early on because I was in an airport in Seattle and felt yucky afterward, and I was COVID negative, and I have had no symptoms since. We haven't had very much. We have had a couple of kids admitted to our hospital in Utah that had it, and we have somebody that we think might have had this MIS-C but wasn't very severe and didn't end up in the ICU. In fact, none of our COVID patients, to my knowledge, have ended up in the ICU. Our kids, different for adults. So it doesn't seem to be quite as flagrant in the Middle West where I live as it is in New York City, and LA, I guess, is getting fairly pummeled with it right now. So maybe we're just lucky, or maybe we have yet to see it and it will be here.
Yeah, I think we're going to be fortunate. I think we are flattening the curve as long as we don't get careless out there with people. Yeah, put those masks on. I'm going to give the last question to you, Susan, from Todd. We don't get a question like this very often. Todd, we might have to do our own homework. And if we do, I'm sure you're not the first adult patient who's wondered about this. But Todd, congratulations on getting your first colonoscopy soon. Let me know how it goes. Full confession, I'm 53. I still haven't gotten mine yet. I'm not the best patient, but I'm working on that part of preventative medicine. He's wondering, seriously, he's wondering about the whole prep business for colonoscopies, which I've only read about, and whether losing electrolytes could wake up his long QT. And is there anything special he should do about his colonoscopy preparation to counter the electrolyte business since he has long QT? What say you, Susan?
So part of my prep, full disclosure, I did get my colonoscopy when I was 50. Part of my prep was actually Gatorade, which has a little bit of potassium in it. And so you can find solutions that contain electrolytes. And I would assume that you're going to be recommended to use some of those solutions, because it isn't just water that we use when we do our colonoscopy prep. And they do have you drink boatloads of liquid. But one of the clear liquids I got to have was Gatorade, and it has some potassium in it. And by Gatorade, I mean Powerade or one of the aids. So.
Well, Carl's jumped online to just reassure you, Todd, and I guess to encourage me that that whole deal down under, bottoms up, isn't so bad. So uh, thanks for that encouragement. Well, Susan, thanks for joining us, and give you sort of your parting words to what you want your SADS families and all of our families out there throughout the globe to be doing as we enter and continue to do this, what I call coexistence with the coronavirus. What would you want to throw out to them as your parting thoughts?
Stay safe, stay healthy, but also live your life within the bounds that are being defined by whatever your organization, your local government is. Live your life.
Great. And speaking of living your life, I have to show you. Let's see if I can do this.
Tip it forward a little bit. There you go.
There. So this was our oldest son, Jager's virtual graduation ceremony last night from Loma Linda Medical School. So he is now Dr. Ackerman. He didn't get a real graduation ceremony, but he got to be with us, or we got to be with him in Green Lake, which you all know what comes with him is let me see. Oh, is
Tip it higher. Go higher and bring it. There you go. Oh, yay.
is Jaden. So they have now moved to Wisconsin, everybody. They move into their home next Friday, and he will be starting his psychiatry residency next month at University of Wisconsin in Madison. So now no more airplanes. They can keep us quarantined for as long as they want to, because now we can just hop in the car and go see her with a 3-hour drive. So you'll get to watch her grow up with even closer photo updates out there. So thank you everyone for joining us. We think of you. Be well, live and thrive, as we at the SADS Foundation want you to do, intend for you to do, and we expect you to do just that. And refuse to fear out there. We'll see you next Friday. Next Friday is going to be really good. Join us. It's a combined SADS Foundation Global, us, with the Canadian chapter of the SADS Foundation. And joining us with from SADS Canada is going to be Robert Hamilton in Toronto, Shu Sanitani in Vancouver, BC,
The
and
funniest man alive.
indeed. And so I hope you'll be able to contain yourself during that 40 minutes. And Andrew Cron from Canada, who's also the new incoming, or no, not yet.
Yeah. Coming in.
The coming in president. No, Christine Albert.
Christine, and then next
Yeah.
year.
So next year, Dr. Andrew Cron will be the president of the Heart Rhythm Society. So the three of them for SADS Canada will be joining us next Friday, same time. Do join us then. And until then, for those of you in the United States, have a blessed Memorial Day weekend.
Oh, happy holiday.
Yeah. Take care, everyone. And thank you to our veterans out there. We think of you this Memorial Day weekend, and blessings to all. Bye, everybody.